You are performing CPR on an adult patient who has collapsed and is unresponsive. Describe the correct steps for administering CPR, including the compression to breath ratio and proper hand placement. Why is it essential to follow these steps precisely? Answer: the correct steps for performing CPR on an adult include: assess the patient's responsiveness by gently tapping and shouting. If unresponsive, call for emergency medical help, check for breathing. If the patient is not breathing or only gasping, begin CPR. Hand placement: place the heel of one hand on the center of the chest, lower half of the sternum, and the other hand on top, interlocking the fingers. Keep the elbows straight. Compression depth and rate: perform chest compressions at a depth of at least 2 inches 5 centimeters at a rate of 100-120 compressions per minute. Compression to breath ratio: after 30 compressions, provide 2 rescue breaths, ensuring that each breath is given over 1 second and the chest rises. Use an AED as soon as available, following its voice prompts for defibrillation. It is essential to follow these steps precisely to maintain adequate circulation and oxygenation until advanced medical help arrives. Effective chest compressions help to circulate blood to vital organs, primarily the brain and heart, and the proper hand placement ensures the effectiveness of compressions without causing injury. A patient arrives at the ER with a third-degree burn on the left arm and shows signs of shock. Describe the appropriate first aid response for both the burn and shock. Include specific interventions and the rationale behind each. Answer: for third-degree burns, immediate care. Remove the patient from the source of heat, e.g. fire, steam. Ensure safety by wearing protective gloves if necessary. Cool the burn. Apply cool, not cold, running water to the burn area for at least 10 minutes to reduce heat and prevent further tissue damage. Do not apply ice as it can cause vasoconstriction and worsen injury. Cover the burn. Use a clean, non-stick bandage or a sterile cloth to cover the burn to prevent infection and reduce pain. Avoid using creams, ointments, or breaking blisters. Pain management: administer pain relievers per protocol, such as opioids or NSAIDs, depending on the severity. For shock positioning: lay the patient flat and elevate the legs if no spinal injury is suspected. This helps improve circulation to vital organs. Oxygen: administer oxygen if needed to increase tissue oxygenation. Fluid resuscitation: if hypovolemic shock is suspected due to fluid loss from burns, start intravenous fluids such as isotonic saline or lactated Ringer solution to restore circulating volume. Monitor vital signs: continuously monitor the patient's heart rate, blood pressure, and respiratory rate for any changes. The primary goal in managing third-degree burns is preventing infection, minimizing pain, and restoring fluid balance in the case of shock. Early intervention can significantly reduce mortality and complications. You need to deliver a diagnosis of terminal cancer to a patient. How would you approach this conversation to ensure it is empathetic and compassionate? What are key communication strategies you would employ? Answer: to ensure the conversation is empathetic and compassionate. Prepare for the conversation. Ensure privacy, minimize distractions, and sit at the patient's level to create a supportive environment. Use clear and simple language. Avoid medical jargon, explaining the diagnosis in a way that the patient can understand. Be direct but gentle. Clearly state the diagnosis while being sensitive to the emotional impact. For example, "I'm sorry to inform you that the tests show the presence of terminal cancer." Acknowledge emotions. Allow the patient to express emotions such as sadness, anger, or fear. Respond with empathy, such as, "I understand this news is very difficult to hear." Offer support. Offer information on treatment options and include family or support persons in the discussion if appropriate. Active listening: let the patient ask questions and express their concerns. Listen attentively, validate their feelings, and provide honest and clear responses. The key strategy here is active listening and ensuring the patient feels heard and supported. A patient is brought into the ER after a motor vehicle accident. You need to perform a rapid head-to-toe assessment. What key findings would you check for in this scenario, and how would you prioritize your actions? Answer: a rapid head-to-toe assessment should focus on identifying life-threatening conditions. The key findings to assess include airway. Ensure the airway is patent. If the patient is unconscious, check for any obstructions or signs of difficulty breathing. Check for adequate ventilation. Observe the chest for movement. Listen for breath sounds and assess the rate and depth of respiration. Circulation: check for signs of bleeding, such as external hemorrhage or internal bleeding. Signs of shock, such as pallor, weak pulse, low blood pressure, head and neck. Assess for signs of head trauma, e.g. bleeding, deformities, unequal pupils, or neck injuries, e.g. spinal cord damage, cervical spine alignment, chest and abdomen. Palpate for tenderness, deformities, and signs of rib fractures. Assess for any signs of abdominal bleeding or distension extremities. check for fractures, deformities, or signs of hypoperfusion. G. Capillary refill, skin temperature in a trauma situation. Prioritize airway management, followed by breathing and circulation acts. Once life-threatening issues are addressed, proceed with a head-to-toe assessment to identify other injuries. Mr. Martinez is a 55-year-old patient of Hispanic descent, and his family is very involved in his care decisions. His daughter insists that no life-sustaining measures be taken, but his son disagrees, requesting all measures be used. How should you approach this situation to navigate the family dynamics and ensure Mr. Martinez's care respects both cultural and legal considerations? Answer: in this situation, you should approach the discussion with cultural sensitivity and respect for the family's values. Acknowledge cultural values. Understand that in some cultures, family members may have significant influence over medical decisions. Approach the family with respect for their values, ensuring that their concerns are heard. Facilitate family discussion. Encourage open communication between the family members to clarify their wishes and concerns. This may involve a family meeting or mediation with a healthcare ethicist. Respect Mr. Martinez's autonomy. If Mr. Martinez is able to communicate, engage him in the conversation and ascertain his wishes regarding life-sustaining measures. If he has an advance directive or living will, refer to these documents to guide the decision-making process. Involve legal and ethical support. If the family remains divided and Mr. Martinez's wishes are unclear, consult with a healthcare ethics committee or legal counsel to ensure the decisions align with both ethical standards and legal requirements. A multi-casualty incident. You are the triage nurse and have identified 3 patients. Patient A: severe chest pain, pale, weak pulse and low blood pressure. Patient B: head trauma with a Glasgow Coma Scale, GCS of 6, actively bleeding from the head. Patient C: mild abdominal pain, stable vital signs, and no signs of distress. How would you prioritize these patients, and what is the rationale behind your decision? Answer: using the START, simple triage and rapid treatment system. Patients are categorized based on the severity of their conditions. Patient B: head trauma, GCS 6, actively bleeding. This patient should be prioritized as red, immediate care needed. Severe head injury combined with a low GCS score and active bleeding indicates a life-threatening condition that requires immediate intervention to prevent brain damage and further complications. Patient E: whistle, chest pain, weak pulse, low blood pressure. This patient may be categorized as red, immediate care needed as well, given the signs of a potential cardiac event, e.g. myocardial infarction or shock. However, the severity of the condition compared to head trauma should be evaluated further. Patient C: stable with mild abdominal pain. This patient would likely be categorized as green minor. Although there is abdominal pain, there are no signs of acute distress or life-threatening injury. In mass casualty scenarios, the goal is to prioritize those who are most likely to survive with immediate intervention, and patient B and patient who would take precedence over patient C. How would you manage an open fracture of the femur in an emergency situation, and what are the immediate priorities? Answer: for an open femur fracture, immediate management steps should include: ensure safety, protect yourself and the patient from further injury, ensure the environment is safe and call for emergency medical services, control bleeding, apply sterile dressing or a clean cloth to the wound to control bleeding, use direct pressure if needed. If bleeding is severe, consider applying a tourniquet above the fracture site, immobilize the fracture, stabilize the limb with a splint to prevent further damage to the bone and surrounding tissues, avoid moving the bone ends. Pain management. Administer pain relievers per protocol, e.g. opioids, NSAIDs. Prevent shock, monitor for signs of shock, e.g. low blood pressure, tachycardia, and initiate fluid resuscitation if necessary. Keep the patient warm and comfortable. The key priorities are controlling bleeding, preventing infection, and minimizing further injury through immobilization. Managing pain and preparing for transport to a medical facility are essential for optimal outcomes. When conducting a rapid assessment of a trauma patient, what are the components of the head-to-toe assessment, and how do you prioritize your assessment steps in this time-sensitive situation? Answer: the head-to-toe assessment in trauma involves a systematic evaluation to identify life-threatening conditions, airway, check for any obstructions, signs of distress, or difficulty breathing, observe for adequate ventilation, lung sounds and respiratory effort, circulation, assess for bleeding, skin color, pulse and blood pressure, head and neck. Check for signs of head trauma, bleeding, deformities, or neurological deficits, e.g. unequal pupils, chest and abdomen. Palpate for deformities, tenderness, or signs of hemorrhage, extremities. Check for fractures, deformities, or signs of impaired circulation in a life-threatening scenario. Prioritize airway, breathing, and circulation acts first, After ensuring these functions are stable, proceed with the head-to-toe assessment, focusing on the areas that indicate the most urgent need for intervention. You need to inform a family that a loved one is in critical condition after surgery. How do you convey the information empathetically while ensuring transparency about the situation? Answer: to deliver the message empathetically, prepare the environment, ensure privacy, and sit with the family to show respect and care. Use clear language. Explain the situation using simple language that avoids medical jargon. Deliver bad news with empathy. Use phrases like, "I'm deeply sorry to inform you that your loved one is in critical condition," while maintaining a calm and compassionate demeanor. Provide accurate information. Explain the specifics of the situation, including the surgical complications, treatment options, and potential outcomes. Allow for emotions. Give the family time to process the news and offer support for any emotional reactions. Offer hope where possible, while being honest about the severity of the condition. Highlight the care and interventions being provided. Empathy helps in building trust, and clear, honest communication allows families to make informed decisions about next steps. How would you apply the START triage system to prioritize care in a scenario involving a bus crash with multiple casualties? Answer: in a bus crash scenario, the START triage system would help prioritize patients based on the severity of their injuries. The key steps are: assess the patient's ability to walk. If the patient can walk, they are categorized as green minor. If not, move on to the next assessment step. Assess respiratory status. If a patient is not breathing, attempt to reposition the airway. If they remain apneic, categorize them as black, dead. If they start breathing, categorize them as red, immediate. Assess circulation. Check for a pulse. If the pulse is weak or absent, or if the patient is in shock, they are red. Assess neurological status. Check for confusion or inability to follow commands. Those with altered mental status are categorized as red. The START system helps prioritize patients by identifying those who need immediate medical intervention, improving the chances of survival for the most critical patients. A patient with borderline personality disorder frequently tests the boundaries set by the nursing staff. The patient often makes requests to meet outside scheduled therapy sessions and expresses anger when boundaries are reinforced. How should the nurse respond, considering the principles of therapeutic communication? Answer: when dealing with patients who have borderline personality disorder (BPD), boundary setting is crucial, as they often test limits due to emotional instability and fears of abandonment. The nurse should respond calmly and assertively, reinforcing the boundaries without being confrontational. For example, the nurse might say, "I understand that you'd like to meet outside of the scheduled sessions, but I need to maintain our boundaries for both your safety and the safety of other patients. We can discuss any concerns during our next scheduled meeting." It's essential to stay consistent with enforcing boundaries, as inconsistency may lead to the patient becoming more anxious or manipulative. Additionally, the nurse should use reflective listening to acknowledge the patient's feelings without agreeing or disagreeing with their behavior. Saying something like, "It sounds like you're feeling frustrated that we can't meet outside of our regular schedule," helps validate the patient's emotional state and may reduce emotional escalation. By maintaining structure, using empathetic communication, and showing that their feelings are acknowledged but the boundaries will not be breached, the nurse can provide stability and support the patient's emotional regulation. What are the primary concerns when administering SSRIs to a patient with a history of bipolar disorder? Answer: selective serotonin reuptake inhibitors (SRIs) are commonly used to treat depression, but they can have significant risks when prescribed to patients with bipolar disorder. The primary concern is that SSRIs can trigger a manic episode in patients who are predisposed to bipolar disorder. SRIs, by increasing serotonin levels, may destabilize mood and shift the patient into mania, especially when used without a mood stabilizer. This is why SSRIs are typically prescribed alongside a mood stabilizer in individuals with bipolar disorder. Additionally, there is an increased risk of serotonin syndrome, a potentially life-threatening condition caused by excessive serotonin activity, which can manifest as agitation, hypothermia, tremors, and altered mental status. The combination of SSRIs with other serotonergic drugs, such as certain pain medications or illicit drugs, should be closely monitored. To minimize these risks, healthcare providers need to ensure that the patient is being properly managed with. A mood stabilizer and any SSRIs prescribed should be initiated at lower doses and closely monitored for early signs of mania or agitation. A detailed assessment of the patient's psychiatric history and current medications is essential before starting SSRI therapy in bipolar patients. Ms. Lopez, a 45-year-old patient with schizophrenia, is in the psychiatric unit after a psychotic episode. She begins shouting at the nurse, accusing them of poisoning her food. How should the nurse handle this situation to de-escalate her behavior? Answer: in situations like this, the nurse must first remain calm and avoid becoming defensive or argumentative, as engaging in a confrontation can escalate the situation further. The nurse should prioritize safety by ensuring that they maintain an appropriate physical distance from the patient, reducing stimuli in the environment, and speaking in a calm and non-threatening tone. The nurse can employ techniques of active listening, acknowledging Ms. Lopez's feelings without reinforcing the delusion. For instance, the nurse might say, "I hear that you are concerned about your food. I'm here to ensure your safety. Let's talk about your concerns." This response validates her emotional state while not supporting the delusional content of her belief. The nurse should also offer Ms. Lopez a safe space to calm down, providing opportunities for her to express her feelings without judgment. If necessary, the nurse can offer her medication, if prescribed, to help manage acute psychosis symptoms. The goal is to reduce anxiety, maintain a therapeutic relationship, and allow the patient to feel heard while simultaneously protecting the therapeutic environment. A patient undergoing a minor surgical procedure refuses a blood transfusion, citing religious beliefs. What should the nurse do to uphold the patient's rights? Answer: the nurse must uphold the patient's right to autonomy, which includes the right to make informed decisions about their healthcare, even if those decisions are contrary to medical advice. In this scenario, the nurse should ensure that the patient fully understands the implications of refusing a blood transfusion, such as the potential for compromised health outcomes. The nurse should confirm that the patient's decision is voluntary and not coerced, which can be done by engaging in a non-judgmental, open conversation. The nurse should document the refusal of treatment, including the patient's expressed reasons for refusal, and inform the healthcare provider of the decision. If the patient is refusing treatment based on their religious beliefs, the nurse should respect those beliefs, provide emotional support, and, if necessary, offer alternative treatment options or consult with an ethics committee. The refusal must be documented clearly to protect both the patient and the healthcare provider from potential legal issues. Relevant guidelines. The ANA Code of Ethics for Nurses emphasizes the importance of patient autonomy, stating that nurses must respect patients' rights to make informed decisions, including the right to refuse treatment. A busy emergency room, a nurse is discussing a patient's medical history within earshot of other patients. What steps should the nurse take to ensure HIPAA compliance? Answer: HIPAA, Health Insurance Portability and Accountability Act, requires the healthcare providers take measures to protect patient confidentiality. Discussing a patient's medical history in a public or shared space violates HIPAA's privacy rule. The nurse should immediately cease discussing the patient's information in an open area and move to a private location, such as a consultation room, to continue the conversation. HIPAA mandates that patient health information (PHI) is shared only with authorized individuals in secure settings. In the emergency room, the nurse should be particularly mindful of the physical environment, ensuring that any patient discussions take place away from others. Additionally, when dealing with electronic health records, the nurse must ensure that patient data is password protected and that only those with a legitimate need to know have access. To prevent future violations, the nurse should be trained in HIPAA compliance and the specific privacy policies of the healthcare institution. The nurse should also report any incidents of potential breaches to the institution's compliance officer. A nurse is caring for an elderly patient who expresses a desire to end their life due to terminal illness and unbearable pain. How should the nurse address this ethically complex situation? Answer: this is a deeply challenging situation that requires the nurse to balance ethical principles of autonomy, beneficence, and non-maleficence. The nurse must first listen actively to the patient's concerns, acknowledging their suffering and providing emotional support. It's essential to explore alternatives, such as pain management, hospice care, or palliative care options that might alleviate the patient's distress. However, nurses must also recognize their professional and legal limits, as assisted suicide or euthanasia is illegal in most jurisdictions. The nurse should communicate the patient's wishes with the healthcare team and explore options for enhancing the patient's quality of life through compassionate care. If appropriate, a referral to a psychiatrist, palliative care specialist, or ethics committee should be made. The nurse must maintain professional boundaries, ensuring that they do not inadvertently encourage or participate in any illegal activities. Relevant guidelines. The ANA Code of Ethics stresses that nurses must provide compassionate care while maintaining patient safety and complying with legal constraints. Ethical decision-making should consider the holistic needs of the patient, balancing their autonomy with the nurse's duty to protect life. What is the purpose of using de-escalation techniques in the management of patients with acute psychotic episodes? Answer: de-escalation techniques are critical in managing patients with acute psychotic episodes because they help prevent violent outbursts, reduce the patient's anxiety, and foster a therapeutic environment. When patients experience psychosis, they may become agitated, fearful, or distrustful of their surroundings. De-escalation strategies, such as speaking in a calm voice, maintaining a safe distance, offering reassurance, and avoiding direct confrontation, aim to help the patient regain control of their emotions and thoughts. De-escalation is preferable to the use of restraints or sedatives, as it promotes patient autonomy and minimizes physical harm. These techniques also create a non-threatening environment that encourages cooperation and facilitates better communication between the patient and the healthcare team. In situations where verbal de-escalation is unsuccessful, other methods such as offering the patient medication or involving a psychiatrist may be necessary. Relevant guidelines. The National Alliance on Mental Illness (NAMI) recommends de-escalation strategies as part of a patient-centered approach to managing acute psychiatric symptoms. Nurses are trained to recognize early signs of agitation and intervene promptly to prevent escalation. A nurse is assigned to care for a patient who has expressed a desire to refuse life-saving treatment due to personal or religious beliefs. The patient's family is advocating strongly for the treatment as they believe it is the only way to save the patient's life. How should the nurse navigate this ethical dilemma, balancing the patient's autonomy with family interests? Answer: in this scenario, the nurse must uphold the patient's autonomy, which is a fundamental ethical principle in nursing. Autonomy refers to the patient's right to make their own informed decisions regarding their healthcare, even if those decisions conflict with the family's wishes or medical advice. The nurse should first ensure that the patient is fully informed about their condition, the consequences of refusing treatment, and all available alternatives. This allows the patient to make a decision that aligns with their personal values. The nurse should facilitate open communication between the patient and the family, respecting both the patient's right to make their decision and the family's concerns. The nurse can act as a mediator, helping the family understand the patient's viewpoint and ensuring that the family's desires are also considered. In cases where the family strongly disagrees with the patient's decision, the nurse should involve other healthcare professionals, such as social workers or ethics committees, to provide support and guidance. It is also important for the nurse to document all discussions and the patient's decision, as this serves as protection for both the nurse and the patient. If necessary, the nurse should seek legal advice or consult institutional policies to ensure that they are complying with relevant laws and guidelines while maintaining the patient's rights. A nurse notices that another nurse has been accessing patient records without authorization. What actions should the nurse take to report the potential breach of HIPAA regulations? Answer: HIPAA, Health Insurance Portability and Accountability Act, requires that patient health information (PHI) be protected and accessed only by individuals with a legitimate need to know. The first step is for the nurse to document the incident, including the date, time, and nature of the unauthorized access. The nurse should then report the situation to their supervisor or the designated HIPAA compliance officer within the organization. In some cases, it may be appropriate to approach the individual involved in the breach if the situation allows, to address the behavior directly and encourage compliance with privacy policies. The nurse who witnesses the breach should avoid discussing the incident with other staff members or patients, as this could further compromise patient confidentiality. It's also essential for the nurse to understand the organization's policies regarding reporting breaches, as there may be specific protocols for addressing HIPAA violations. In cases where the breach is severe or repeated, the nurse may need to escalate the matter further, involving the organization's legal department, the Department of Health and Human Service (HHS), or other regulatory authorities as required. A nurse is caring for a patient with severe anxiety who is experiencing a panic attack. The patient is hyperventilating, sweating, and unable to focus. What steps should the nurse take to help the patient manage the panic attack and de-escalate the situation? Answer: when managing a patient experiencing a panic attack, the nurse's primary goal is to reduce the patient's anxiety and help them regain control of their breathing and emotions. The nurse should start by creating a calm and quiet environment, removing any potential stressors and ensuring privacy if possible. First, the nurse should approach the patient calmly, speaking in a low, steady voice. It's important to avoid raising the nurse's own anxiety, as the patient may pick up on this and feel more overwhelmed. The nurse should reassure the patient that the symptoms, they're distressing, are not life-threatening and that they will help the patient through the episode. One of the most effective interventions is to guide the patient through controlled breathing exercises. The nurse can instruct the patient to breathe in slowly through their nose for 4 counts, hold the breath for 4 counts, and then exhale slowly through the mouth for 4 counts. This technique helps to regulate the autonomic nervous system and reduces hyperventilation. The nurse should also encourage the patient to focus on grounding techniques, such as identifying objects in the room or tapping their fingers to redirect their focus away from overwhelming thoughts. If the panic attack is prolonged or severe, the nurse should consider administering medications as prescribed, such as a benzodiazepine, and inform the healthcare provider for further evaluation. Relevant guidelines. The American Psychiatric Nurses Association now highlights the importance of grounding and breathing exercises in managing panic attacks. Crisis intervention techniques that include calm reassurance and non-judgmental support are crucial in helping patients regain emotional stability. Nurses are also trained to recognize when pharmacological interventions are necessary for acute anxiety management. A 6-year-old child is recovering from a tonsillectomy. The nurse is assessing the child's pain level using the Wong-Baker FACE pain rating scale. The child points to a face indicating a level 6 pain. What steps should the nurse take next, considering the best approach to manage pediatric pain and avoid complications related to undertreatment? Answer: when managing pediatric pain, particularly in post-operative recovery, accurate assessment is essential. After identifying the pain level, in this case a 6 on the Wong-Baker FACE scale, the nurse should validate this finding by observing the child's physical and behavioral signs. Children may express pain through crying, irritability, restlessness, and changes in behavior, and these should be noted. Once pain is confirmed, pharmacologic treatment is necessary. For children, acetaminophen or ibuprofen can be used for mild to moderate pain, while opioids may be indicated for more severe pain, always balancing efficacy with the potential for side effects such as sedation and nausea. In addition to pharmacologic treatment, non-pharmacological strategies should be considered. These may include distraction techniques, e.g. watching TV, playing with toys, guided imagery, and relaxation exercises to reduce pain perception, positioning the child comfortably, applying cold compresses to reduce swelling, and offering small, frequent meals can help improve comfort. The nurse should also monitor for adverse effects of pain medications, including respiratory depression, and educate parents or caregivers on what to do if the pain seems inadequately controlled. An elderly patient with osteoarthritis is unable to take nonsteroidal anti-inflammatory drugs (NSAIDs) due to renal issues. What non-pharmacological strategies can the nurse implement to effectively manage the patient's pain, considering the patient's age and medical restrictions? Answer: when treating elderly patients with osteoarthritis who are unable to use NSAIDs due to renal issues, non-pharmacological pain management strategies are essential. The nurse should focus on providing relief through methods that do not compromise kidney function. A combination of physical and psychological interventions can be highly effective. First, the nurse can recommend heat or cold therapy. Heat, such as warm compressors or heating pads, helps relax muscles and alleviate joint stiffness, while cold therapy, ice packs, or cold compressors can reduce inflammation and swelling. These methods should be used with caution, ensuring that the patient does not experience burns or frostbite, especially if they have impaired sensation. Secondly, physical therapy can be beneficial for increasing mobility and strengthening muscles around the affected joints. Tailored exercise programs can help reduce pain and improve functionality. The nurse may collaborate with a physical therapist to create a plan suited to the patient's ability and preferences. Additionally, cognitive behavioral techniques such as relaxation training, guided imagery, and meditation can help the patient manage pain perception and reduce anxiety associated with chronic pain. These interventions are particularly useful in elderly patients as they help alleviate both the physical and emotional components of pain. The nurse should also educate the patient on weight management, as maintaining a healthy weight can decrease strain on joints, particularly the knees and hips. Dietary modifications, such as anti-inflammatory foods, e.g. omega-3 rich foods, may also complement pain management. Finally, the nurse should regularly reassess the patient's pain and quality of life, ensuring that the pain management strategies remain effective and safe and involve the patient in decision-making regarding their treatment plan. Mr. Thompson is a 75-year-old patient who has been diagnosed with terminal cancer and is receiving hospice care. He is experiencing severe pain that is not controlled by the prescribed opioids. His family is very emotional and they are struggling with the idea of increasing opioid doses. What should the nurse do in this situation to ensure Mr. Thompson's comfort and respect for his family's concerns? Answer: in end-of-life care, the primary goal is to ensure the comfort and dignity of the patient while also providing emotional support to the family. The nurse should first assess Mr. Thompson's pain using appropriate pain scales, such as the numeric rating scale, and evaluate whether the current opioid regimen is adequate. If pain remains uncontrolled, the nurse should work with the healthcare team to reassess and possibly increase the opioid dose or explore additional medications like adjuvants, e.g., corticosteroids or anticonvulsants to manage breakthrough pain. It's important to approach this sensitive situation with compassion and clear communication. The nurse should explain to the family that pain management in palliative care focuses on comfort, not curative treatment, and that increasing the opioid dose is not intended to hasten death but to alleviate suffering. The nurse should also involve the hospice team, including the physician, social worker, and chaplain, to address both the physical and emotional needs of the family. A family meeting may be helpful to ensure that all concerns are heard and addressed. Finally, emotional and psychological support for the family is critical. A postpartum mother presents with signs of excessive bleeding, including a bright red, large amount of blood loss. The nurse notes that the uterus is soft and not contracted. What is the nurse's immediate priority in managing this situation, and what underlying mechanisms should be considered for the condition? Answer: excessive postpartum bleeding, particularly when the uterus is soft and non-contracted, suggests uterine adyny, which is one of the most common causes of postpartum hemorrhage. The nurse's immediate priority is to prevent further blood loss and stabilize the mother. The first intervention should be to perform a fundal massage to help stimulate uterine contraction. Uterine atony prevents the uterus from contracting properly, leading to uncontrolled bleeding. If the uterus does not respond to manual massage, the nurse should immediately administer uterotonic medications such as oxytocin, methylgonavine, or prostaglandins as prescribed. These medications help the uterus contract and reduce bleeding. In cases where bleeding continues despite these measures, the nurse should notify the physician for further interventions, which may include uterine tamponade, balloon therapy, or surgical interventions such as a DC dilation and curettage, or even a hysterectomy if necessary. The nurse should closely monitor vital signs, especially blood pressure and heart rate. For signs of shock, blood products may be needed if the hemorrhage is severe, so the nurse should prepare for blood transfusions if ordered. Intravenous fluids should be administered to maintain circulating blood volume. A 2-month-old infant is brought to the clinic for routine vaccination. The nurse is reviewing the immunization schedule. Which vaccines are required at this visit, and what are the primary considerations for ensuring the infant's safety during this process? Answer: at 2 months of age, the infant should receive a series of vaccinations as part of the routine immunization schedule recommended by the CDC. These vaccines include DTaP, diphtheria, tetanus, and pertussis IPV, inactivated poliovirus, Hib, Haemophilus influenzae type B, PCV, pneumococcal conjugate vaccine, RV, rotavirus, hepatitis B. If not previously administered, the nurse should verify that the infant is healthy and not exhibiting signs of illness before administering vaccines, as vaccines should be deferred in the presence of fever or active illness. It is also essential to ensure that the infant is well hydrated and comfortable prior to the vaccinations. The nurse should administer the vaccines according to the recommended injection sites and ensure proper storage of vaccines according to manufacturer guidelines. The nurse should be prepared to manage potential side effects such as mild fever, redness, or swelling at the injection site, which are common and generally self-limiting. Parents should be educated about these possible side effects and provided with guidance on when to seek further medical attention. For instance, if the infant develops a high fever or exhibits signs of an allergic reaction, e.g., difficulty breathing, swelling around the eyes or lips, the parents should be instructed to seek immediate medical help. Post-vaccination, the nurse should observe the infant for 15 minutes or 30 minutes if the infant has a history of allergic reactions, to monitor for any acute allergic reactions, including anaphylaxis. Emergency equipment, such as epinephrine and resuscitation supplies, should always be available during vaccinations. A post-operative patient is prescribed hydrocodone for pain relief after abdominal surgery. The nurse notices that the patient has not had a bowel movement in 3 days. What is the nurse's assessment and plan of care, and how does opioid use contribute to the patient's condition? Answer: opioid use is a common cause of constipation in post-operative patients. Hydrocodone, an opioid analgesic, slows gastrointestinal motility, which can lead to constipation, a common side effect. The nurse should assess the patient's bowel sounds and overall abdominal status. It's important to inquire about the patient's typical bowel habits and if they've experienced any discomfort, bloating, or nausea. The nurse should encourage the patient to increase fluid intake and dietary fiber if permitted. Early mobilization, even small movements, can also help stimulate bowel function. The nurse should assess for signs of impaction such as abdominal distension or tenderness and report findings to the healthcare provider if needed. In addition to these measures, the nurse may initiate pharmacologic interventions such as administering a stool softener or a mild laxative like docusate sodium as prescribed. In some cases, more aggressive treatments like enemas or prescription laxatives may be required. The nurse should regularly monitor the patient's bowel movements and continue to assess pain levels to ensure that both pain and constipation are adequately managed. A 9-year-old child with leukemia is undergoing chemotherapy and is experiencing both pain and anxiety. The nurse needs to develop an effective pain management plan while addressing the child's emotional well-being. What strategies can the nurse use to manage this dual challenge, considering both the pharmacologic and non-pharmacologic approaches? Answer: in pediatric oncology patients, effective pain management and addressing emotional distress are critical components of care. The nurse should begin by assessing the child's pain using an appropriate pain scale for their age, such as the Wong-Baker FACE pain rating scale or the FLA-CC scale, face, legs, activity, cry consolability, for younger children. This will guide the selection of an appropriate pharmacologic treatment. Mild to moderate pain may be managed with non-opioid analgesics, such as acetaminophen or ibuprofen, while moderate to severe pain may require opioids like morphine tailored to the child's weight and medical condition. The nurse should monitor for potential opioid side effects, such as respiratory depression or constipation, and address these proactively. In addition to pharmacologic interventions, non-pharmacological strategies are crucial for managing anxiety and improving the child's overall sense of well-being. These strategies include distraction techniques, such as watching a favorite show or playing with toys, which can shift the child's focus away from the pain and treatment. Guided imagery, where the child imagines a calming place or scenario, can also be effective in reducing anxiety and providing emotional relief. Another approach is cognitive behavioral therapy (CBT), which can help the child develop coping mechanisms for both pain and anxiety. Additionally, relaxation techniques such as deep breathing exercises can be taught to help the child manage moments of heightened anxiety during chemotherapy or painful procedures. The nurse should also involve the family in the process, offering them support and education on how they can assist the child in managing pain and anxiety. Moreover, maintaining a routine and ensuring that the child feels in control where possible, such as allowing them to make simple decisions, can reduce feelings of helplessness and anxiety associated with illness and treatments. Support from a child life specialist or a psychologist trained in pediatric oncology is often beneficial in addressing the emotional challenges of treatment. A 68-year-old patient is recovering from a total hip replacement surgery. The patient is experiencing moderate pain and has difficulty moving the leg. What steps should the nurse take to manage the patient's pain and facilitate early mobility, considering the patient's age and the nature of the surgery? Answer: postoperative care for a patient who has undergone hip replacement surgery focuses on effective pain management, preventing complications and promoting early mobility. The nurse should first assess the patient's pain using a standardized pain scale, such as the numeric rating scale (ARS) or Wong-Baker FACE scale, and provide appropriate analgesia. For moderate pain, non-steroidal anti-inflammatory drugs (NSAIDs), such as ibuprofen or acetaminophen, may be effective, but for more severe pain, opioids like morphine or hydrocodone may be required. The nurse should monitor for opioid side effects such as sedation or constipation and address these as needed. In addition to pharmacologic treatment, non-pharmacological pain management strategies should be employed. These may include the application of ice packs to the hip area to reduce inflammation, positioning the patient for comfort, and using relaxation techniques like deep breathing to help manage pain perception. The nurse should also monitor for signs of complications such as infection, deep vein thrombus (DVT), or dislocation of the hip joint. Early mobilization is essential for improving outcomes after hip replacement surgery. The nurse should collaborate with physical therapy to develop an individualized plan for the patient, which may include assisted walking with a walker, leg exercises to prevent stiffness, and gradually increasing activity levels as tolerated. It is crucial that the patient is encouraged to begin moving as soon as possible to prevent complications like DVT, pneumonia, or muscle atrophy. Additionally, the nurse should educate the patient about the importance of weight-bearing restrictions and avoiding positions that could cause hip dislocation, such as crossing the legs or bending the hip beyond 90 degrees. Clear instructions on post-operative care, including the use of assistive devices and the importance of following the surgeon's guidelines, should be given to the patient and their family to ensure proper recovery. A 28-year-old woman 3 weeks postpartum, presence to the clinic with complaint of persistent sadness, loss of interest in daily activities, and difficulty bonding with her newborn. What steps should the nurse take to assess and address the possibility of postpartum depression (PPD), and what interventions should be considered? Answer: postpartum depression (PPD) is a serious condition that can negatively impact a mother's emotional well-being, her relationship with her infant, and the family dynamics. The nurse should begin by conducting a thorough assessment of the mother's symptoms using tools such as the Edinburgh Postnatal Depression Scale (EDS) or the Postpartum Depression Screening Scale (PSS) to evaluate the severity of depressive symptoms. Key indicators of PPD include persistent sadness, loss of interest in activities once enjoyed, excessive fatigue, feelings of worthlessness, and difficulty bonding with the baby. Once PPD is suspected, the nurse should communicate these concerns to the healthcare provider, who may further assess the need for treatment, which could include psychotherapy or medication. Cognitive behavioral therapy (CBT) is often recommended for new mothers with mild to moderate depression. For moderate to severe cases, pharmacotherapy such as selective serotonin reuptake inhibitors (SRS) may be considered. The nurse should educate the mother on the potential risks and benefits of medications, especially if breastfeeding, and the healthcare provider may suggest medications that are compatible with breastfeeding, such as sertraline or fluoxetine. In addition to formal treatment, the nurse should provide emotional support and reassurance to the mother, helping to normalize her feelings and reduce the stigma often associated with postpartum depression. The nurse should encourage the mother to reach out for social support, whether from family, friends, or a support group for new mothers. Self-care strategies, including adequate sleep, exercise, and healthy eating, should be discussed. Although these may be difficult to implement when dealing with the demands of a newborn, the nurse should also assess the mother's risk for harm to herself or her baby, as PPD can sometimes lead to thoughts of suicide or infanticide. If there is any indication of these risks, immediate intervention is necessary, which may involve referring the mother to a mental health professional or emergency care services. An 80-year-old patient with advanced chronic obstructive pulmonary disease (COPD) is admitted for acute exacerbation. The patient is experiencing significant shortness of breath and anxiety. What strategies should the nurse implement to manage the patient's pain and anxiety while considering the patient's age and respiratory condition? Answer: managing pain and anxiety in geriatric patients with COPD requires a delicate balance of pharmacologic and non-pharmacologic interventions, particularly since older adults are more sensitive to medications and may have multiple comorbidities. The nurse should first assess the patient's level of pain using an appropriate pain scale, such as the Numeric Rating Scale (RS), while also evaluating the patient's shortness of breath using tools like the Borg Dyspnea Scale. For pain management, the nurse should prioritize non-opioid analgesics, such as acetaminophen or NSAIDs if not contraindicated, as opioids can depress respiration and exacerbate respiratory distress in COPD patients. If opioids are required for severe pain, the nurse should start with the lowest effective dose and closely monitor respiratory status, as well as consider the use of short-acting formulations to minimize the risk of respiratory depression. In addressing anxiety, which can be exacerbated by respiratory distress, the nurse can implement non-pharmacological interventions such as guided breathing techniques, which promote relaxation and help reduce the feeling of breathlessness. Positioning the patient in a comfortable semi-Fowler's position can also improve respiratory mechanics and decrease anxiety. Pharmacologic interventions for anxiety might include benzodiazepines, but due to their sedating effects, they should be used cautiously, especially in the elderly. Medications like lorazepam or alprazolam may be considered, but the nurse should monitor the patient for potential side effects, such as confusion or sedation, which can increase the risk of falls. The nurse should also collaborate with the healthcare team to optimize the management of the patient's COPD exacerbation, which may include bronchodilators, corticosteroids, and oxygen therapy. Non-invasive positive pressure ventilation (NIV) may be necessary if the patient's respiratory status worsens. Lastly, the nurse should provide emotional support to the patient, reassuring them that their symptoms will be managed and that the healthcare team is working to improve their comfort.